Hi, welcome back to Patient Education for the Educated Patient. We're talking about failed second stage of labor. This is part 3 of a 3-part series. If you watched part 1, you remember that about 20% of patients are going to find themselves in a difficult situation where you need your doctor's help to safely deliver the baby, either with a C-section, forceps, or a vacuum-assisted device. The second part of this video series addressed the most common misconceptions when it comes to delivering a baby with operative deliveries. And the third part of this video series is going to address a lot of the details and the minutia when it comes to factoring in various complications, complication rates, which complications you worry about. So it may be too detailed for the average patient. This video may be more suitable for medical students, residents, or OBGYN attendings. But I felt the need to make this video and post it on the internet for patients, because if you just watch parts 1 and 2, you'll almost get the feeling that I left you hanging. So this is part 3 to kind of wrap it all up. But if this doesn't make sense, don't be alarmed. Parts 1 and 2 lay a great foundation for you to build upon so that you can have an educated conversation and decision-making process with your doctor about what's best for you and your baby. So let's start part 3. The take-home points. Number 1, balancing the risks and benefits of different delivery options in the second stage of labor is very complicated. It's very, very complicated. So don't feel bad if you can't follow along. Number 2, don't force your doctor out of their comfort zone. I cannot stress this enough. I've heard too many stories where patients and doctors aren't on the same page, and ultimately they do something that somebody's not comfortable with. And this is a very, very risky situation and puts you at a high risk for a very poor outcome. So please don't force your doctor out of their comfort zone. So the complications, we're talking about complications specifically in respect to the operative deliveries. And again, operative deliveries are an umbrella term that include cesarean sections and operative vaginal deliveries. Operative vaginal deliveries are then subdivided into forceps-assisted vaginal deliveries and vacuum-assisted vaginal deliveries. So when I was a medical student, one of the OBGYN attendings kind of told us this analogy that didn't make sense until I practiced obstetrics for several years. Obviously, it's a gross oversimplification of things, but it does help you understand the greater picture. And so she said, when a baby is stuck in the second stage of labor, it's like the baby's stuck down in this hole. And you only have 3 options. Number 1, you can make the hole bigger. Number 2, you can make the head smaller. Or number 3, you can dig a new hole. And what she meant by that was, if you make the hole bigger, that's kind of akin to doing a forceps-assisted vaginal delivery, because the biggest risks with forceps-assisted vaginal deliveries is that you have bigger tears to the vagina, and that's because the forceps are rigid. They will definitely protect the baby's head, but at the expense of the birth canal. The second part of that is that if you make the head smaller, and that's kind of what happens with vacuum-assisted vaginal deliveries. Vacuum-assisted vaginal deliveries have a very long, elongated head with a big bump at one end. There's a higher chance of retinal hemorrhages and other types of intracranial bleeding processes that are not prevalent, but they can happen with vacuum-assisted vaginal deliveries. And then the third thing, when she said dig a new hole, that meant a C-section. Make a new hole above the patient's birth canal and deliver the baby that way. So obviously a gross oversimplification of a very complicated subject, but it's something that definitely stuck with me through all these years. So, summary, again, oversimplified, but vacuum-assisted vaginal deliveries tend to have more fetal risks with cephalehematomas, subgaleal hematomas, shoulder dystocia, etc. Forceps deliveries are associated with more risks to the mother. You're going to have larger perineal trauma or higher risks of anal sphincter injuries, vaginal lacerations such as sulcal lacerations, and both of which can cause higher blood loss. And then finally, C-sections. C-sections are high risk to moms and babies. And we did talk about that in the second part of this video series. If you recall, there was a meta-analysis comparing the risks to moms and babies in first versus second stage cesarean sections. And second stage C-sections had a much, much higher risk to both the mom and the baby. So something to keep in mind. Now, research limitations. So we're going to talk about a few general topics and some specific examples. The first is going to be complications. What really matters? There's long-term complications, which we really worry about. And then there's short-term outcomes that can increase your risk for those long-term complications. And the reason these are the ones that are reported in research studies is because it's easier to do that type of research publication because you don't always have the luxury of following these patients for 10, 15, 20 years down the line to see if there's any major long-term complications for the mom or baby. So what you do is you report on these short-term outcomes because they do correlate and help predict what your long-term risk is for some of these long-term outcomes and long-term complications. So one example, cephalohematoma versus a permanently calcified hematoma. So cephalohematoma is a bump on the baby's head that results from vacuum-assisted vaginal deliveries or abnormal labor curves. And the incidence is anywhere from 2 to 3% for any kind of labor dystocia, C-section after labor dystocia, or forceps-assisted deliveries. But it's somewhere, 10 to 15% for vacuum-assisted vaginal deliveries. It sounds high, but a majority of these cephalahematomas will go away with no sequela whatsoever. Occasionally, some of them will get infected or become permanently calcified and become this permanent hard lump on the baby's head. And so those are the ones that you want to avoid and follow and make sure that doesn't happen. So some definitions. Cephalohematoma is actually blood accumulating under the scalp, and it never crosses the midline. So it's either on the left or the right. It can't be on both sides. The most common lump, however, is just tissue edema right here. We call that capit. And that is totally benign. It will go away with time, and almost all babies have some degree of capit, even without a forceps vaginal delivery or vacuum-assisted vaginal delivery. That can occur with just plain pushing the baby through the birth canal. Now, the most dangerous one is a subgleal hemorrhage or subgleal hematoma. That can be very life-threatening and very serious for a baby if it's not diagnosed and treated early on. So the worst thing that can happen with a subgleal hematoma is that it's mistaken for something more benign like a cephalohematoma or capit. So this is a study that kind of prospectively looked at these cephalahematomas. And so they had 6,000 vaginal deliveries, 3.6% vacuum-assisted vaginal deliveries, which had 40, quote, remarkable cephalahematomas that warranted very close follow-up. And out of these 40, only 6 actually needed to be drained with aspiration. So less than 3% of all the vacuum-assisted vaginal deliveries actually had a cephalohematoma that needed to be drained and compressed so that it didn't turn into a permanent lump on the baby's head. So side note is that if your baby does have a cephalohematoma, make sure it gets followed up. Because if it's still there after 4 weeks, you may need a referral to a specialist to see if there's any kind of procedure that can help prevent that lump on its head from becoming permanent. It may just be for cosmetic reasons, but it's worth the follow-up. Another complication that's commonly cited with operative vaginal deliveries is injury to the anal sphincter. So again, fecal incontinence would be the one complication you want to avoid, and patients with injury to the anal sphincter don't necessarily develop fecal incontinence. It definitely depends on how well it's repaired, if it gets infected, if it forms a fistula, etc. So there's a lot of factors, but just because you have an anal sphincter injury doesn't necessarily mean you'll experience fecal incontinence. So this is a very well done study with 20 years of follow-up after a single delivery, both vaginal deliveries and C-sections, and they studied both fecal and anal incontinence. And what they found is that fecal incontinence is the one that really correlates to dysfunction of the pelvic floor during birth trauma and not so much anal incontinence. So we'll be focusing on the fecal incontinence outcomes after delivery and the various risk factors. So an important thing to note is that fecal incontinence doesn't just depend on how you delivered your baby. It correlates with age, the birth weight, and the BMI. And most importantly, your body mass index or your BMI. If you lose weight, you will have improvement in your fecal incontinence. So whereas you can't modify your age or the birth weight of the baby or go back in time and change how you delivered the baby, what you can control is your weight, and controlling your weight can improve your outcomes. So that's a very important point to take from this. So let's look at the fecal incontinence rates for vaginal delivery versus C-section. What you can see is that with vaginal delivery, there's about a 14.2% incidence after 20 years and 11.6% incidence after a C-section. So again, a couple important takeaway points. Just because you had a C-section, it doesn't necessarily prevent fecal incontinence. Still, 1 out of 9 patients had fecal incontinence 20 years after a C-section. But of course, the vaginal delivery rate did have a higher incidence by about 22%. Now, let's talk about complications during the delivery itself, vaginal deliveries. So looking again at the fecal incontinence, you can see in the first comparison where you have a anal sphincter injury versus no anal sphincter injury, you still had a higher chance of fecal incontinence if there was injury to the anal sphincter, but it's not 100%. Here they found 22.8%. But even if there was no tear into your bottom, into your anal sphincter, you still had about a 14% chance. So the relative risk was higher by about 64%, but it's definitely not zero if you avoid tearing into the anal sphincter. The other point I want to make here is they looked at anal sphincter injury versus episiotomies. And so this is very important because a lot of people are now being forced to report episiotomy rates. A lot of people on their birth plan check the box no episiotomy. I mean, who would volunteer for that? No one's volunteering for that. The doctor's not voluntarily doing it. Episiotomies do have a role, and episiotomies done in the right setting can prevent injury to the anal sphincter. And that's what this study demonstrates and improves, that episiotomies have half the incidence of fecal incontinence than an anal sphincter injury. So it's something to keep in mind that an episiotomy is not necessarily a bad thing when used in the proper setting. Here, it actually cut the risk of fecal incontinence in half instead of letting patients tear into the anal sphincter. So, some of the key points here. Anal sphincter injury does not always lead to fecal incontinence. That's very, very important to understand. Fecal incontinence can happen after a C-section. So if you're thinking a C-section is going to avoid that complication down the road, that's not true. Fecal incontinence can also happen after a perineal injury that does not involve the anal sphincter. So in terms of first and second degree tears, if you avoided a third and fourth degree tear, you can still have fecal incontinence. And then finally, fecal incontinence correlates with age and BMI. And probably the most important takeaway point is that a reduction in your BMI has a reduction in fecal incontinence. So that's a modifiable risk factor that you can control to improve your symptoms if you are affected with this complication. So more complications. Long-term neonatal complications. That's probably priority number 1 for most moms stuck in the second stage of labor. They want to know what's the best thing for the baby. So again, you can talk about cephalehematomas for the baby or retinal hemorrhages, but those things don't necessarily correlate to long-term bad outcomes. The things that do correlate to long-term bad outcomes for the baby are Number 1, neonatal seizures. Number 2, intraventricular hemorrhages. Number 3, subdural hemorrhages. And number 4, a 5-minute APGAR score less than 7. So these are the 4 outcomes you are interested in if you want to know how well the babies do after C-section, vacuum, and forceps. These are predictive of long-term neurological complications for babies. This is an excellent study that specifically looked at neonatal intracranial injury based on C-section delivery, vacuum delivery, and forceps delivery. So one of the issues is the C-sections were all bundled together. It doesn't necessarily separate out just the second stage C-sections. Unfortunately, it lumped in all the first and second stage C-sections. And as we discussed before, all the way back in our second part of this video series, a second stage C-section has a very, very high risk for neonatal complications. So in this study, they focused on the 4 things that did have long-term impaired neurological outcomes for babies. And you can see they even quantify it based on other studies. Severe disabilities of 50% with neonatal seizures, 36% with intraventricular hemorrhage, and 33% with subdural hemorrhage. So these are known to increase the risk of long-term neonatal complications and neurological complications. The second limitation when you're looking at data and research studies is a randomized controlled trial versus a retrospective review. A randomized controlled trial is good for comparing like vacuums to forceps heads up. But in real life, you're not trying to say one instrument is better than the other. I should use that 100% of the time. We also touched on this in the second part of this 3-part video series. Remember the slide comparing a hammer to a screwdriver to a saw? These are 3 different tools. It depends on the situation at hand, the task at hand, and then you can pick the best tool for that situation. So when you look at retrospective reviews, physicians have already, or presumably have already factored in all these things and chose the instrument of choice. And therefore, a retrospective review sometimes has better model for what real world or expected outcomes or complications would be. So here, the mode of delivery for nulliparous women and neonatal intracranial injury, they did a retrospective review. So this was not a randomized controlled trial. Again, they did not really separate out C-sections between first and second stage, but their data is pretty compelling. If you look at forceps compared to vacuum-assisted deliveries, a little bit more of a fairer comparison, you'll see that forceps had less cephalehematomas, more facial nerve palsy, and lower neonatal seizures, lower incidence of a low 5-minute APGAR score, and the composite neurological complication rate was also lower with the forceps. When you look at it compared to C-section or vacuum, against C-section, like I said, it's harder to delineate the significance of the data because first stage and second stage C-sections are lumped together. And when you're faced with this situation, you don't get to go back and choose to do a first stage C-section. You're stuck doing the high risk second stage C-section. So this is a randomized trial comparing vacuums and forceps. It was done a long time ago when vacuums were kind of first being introduced. So that's going to change the outcomes a little bit, as you'll see further down this presentation. We'll address why older studies aren't necessarily applicable to today or modern times for a number of reasons. But this was a randomized trial, and they looked at 5-year follow-ups, and they basically found no difference between the groups, kind of testifying to the fact that you need to use the best instrument for the situation at hand, that forceps aren't better than vacuums and vacuums aren't better than forceps when you look at randomized trials. You can see that their conclusions, there was no difference between bowel or urinary dysfunction, and there was no difference between visual function between the two groups. And the reason they looked at visual function for babies is because of the retinal hemorrhages that are more common with vacuum assisted deliveries. But again, long-term complications of retinal hemorrhages, rare and very, very few. So long-term, no differences in the visual functions between vacuum-assisted deliveries and forceps-assisted deliveries when you randomized the mode of delivery. So the last research limitation, which we kind of prefaced, is trends over time, the pendulum of medicine. So this is a graph of the percentage of forceps-assisted vaginal deliveries and the percentage of ventouse or vacuum-assisted vaginal deliveries. Ventouse is the term used in Europe. So the blue is forceps-assisted vaginal deliveries. And you can see the forceps deliveries really went down as vacuums became more and more popular. But since 2000, they started seeing more complications with vacuum-assisted deliveries because at the beginning, you're only doing very, very, very easy operative vaginal deliveries with the vacuum because it wasn't tried and true, hadn't been tested. People were still getting very familiar with it. So they were only using it for very, very simple and straightforward operative vaginal deliveries. But the problem with that is that over time, you start doing too many cases with a vacuum and you start hitting a lot of complications, maybe subglial hematomas, for example, which we talked about can be life-threatening for the baby. And all of a sudden, it definitely automatically curtails the incidence of vacuum-assisted vaginal delivery. So you can see a dip. And of course, if that is going to go down, the incidence of forceps will go up to kind of fill the unmet need. So you can see how they kind of cross and then they're crossing back over because we probably did a overcorrection. Did very, very few vacuums, did too many, saw a lot of complications, and now we have to back off. And so we're going to find that sweet spot where we balance the number of forceps-assisted vaginal deliveries with the number of vacuum-assisted vaginal deliveries. But the point of this is that it definitely throws a wrench into comparing studies over time. If you're comparing studies from the 1980s and you know they're only doing very easy vacuum-assisted vaginal deliveries, that can make the vacuum seem more favorable. Whereas if you're looking at studies from 2000, well, maybe we're doing too many vacuum-assisted vaginal deliveries and it's going to make the forceps look more favorable than they are. So again, the truth is going to be somewhere in the middle as that pendulum kind of settles into a good balance between forceps-assisted vaginal deliveries, vacuum-assisted vaginal deliveries, and C-sections. So just to summarize some of that data, these are more recent papers. And like I said, they tend to favor forceps, but I don't know if that's because forceps are better or if that's because we were doing too many vacuums. So you can see the conclusion from this study that we talked about, looking specifically at neonatal intracranial injuries and focusing on the outcomes that had a higher chance of impaired neurological outcomes for the baby. Their conclusion was that forceps-assisted vaginal delivery is associated with a reduced risk of adverse neonatal neurological outcomes. This other paper had a similar conclusion. Compared with neonates delivered by cesarean, the neonatal adverse composite was significantly lower among neonates born to nulliparous, which means first-time women, who underwent attempted forceps. And the incidence was 9.4% compared with 16.7%. But not among those who underwent vacuum-assisted vaginal delivery. So another paper favoring forceps, but again, that could just be a reflection of the trends in time. And then lastly, this paper is also relatively recent, and they said that forceps delivery was associated with reduced risk of adverse neonatal outcome compared to vacuum extraction, with no increased risk in composite maternal complications. So again, it's very hard to interpret this data when you factor in trends over time. Like I said, these may have all been studied when we were doing too many vacuum deliveries and having way too many complications for both mom and baby, and we backed off of it and started doing more forceps again. So This is that graph one more time, just to illustrate that point where forceps became very unpopular and now they're rising in popularity again. Vacuums got too popular and we started backing off of them. So in summary, again, way too simplified, but vacuum-assisted vaginal deliveries tend to have higher risks for the baby, cephalehematomas, subgleal hematomas, shoulder dystocia. Forceps deliveries are associated with higher risks to the mom, including anal sphincter injuries, vaginal lacerations, blood loss. And then C-sections, like we talked about specifically, second stage C-sections have a very high risk compared to first stage C-sections. And of course, that's a higher risk to both mom and the baby. So you really have to hone in the situation and all the details to figure out the best way to deliver babies, whether it be by C-section, vacuum, or forceps. And that decision has to be made with your doctor. You cannot push your doctor out of his or her comfort zone. And so again, the take-home points, balancing the risks and benefits of different delivery options in the second stage is very complicated. And number two, do not force your doctor out of their comfort zone. I cannot emphasize that enough. Like I said, I've heard too many stories, reviewed too many legal cases where patients and doctors weren't on the same page and had a horrible, terrible outcome. So really try to educate yourself, have a conversation with your physician, make sure you guys are on the same page, and find out ahead of time what they're comfortable with. Some doctors are not doing vacuums at all. Some doctors are not doing forceps at all. Some doctors are not doing either, and they're only doing C-sections. In fact, a lot of doctors are moving towards C-sections only because either they're not comfortable with vacuums and forceps or they're afraid of the liability. And you can see how if you take that 20% of people stuck in the second stage of labor and do all C-sections, and you lump that into the 23% getting C-sections in the first stage of labor, where you had no other choice, you'll see a C-section rate higher than 40%. And that's a lot of doctors. I mean, the average C-section rate in this country is somewhere like 35%, and everybody's trying to bring it down. But you can't just forcefully bring it down. You really have to bring it down with very skilled and careful operative vaginal deliveries. So we need to make both of those more commonplace to lower the C-section rate, but you got to do it safely. You can't take somebody who doesn't feel comfortable doing vacuum and forceps and force them into doing vacuums and forceps. That's the take-home point that I've said maybe 4 or 5 times in this video alone. So don't force your doctor out of their comfort zone. Find out ahead of time what they're comfortable with, what you're comfortable with, so you guys are on the same page, okay? So thanks for making it to the end of this video. Like I said, it's going to get very complicated. Don't feel bad if you got lost along the way. You can watch the video again. If it still doesn't make sense, like I said, you have enough of a foundation from parts 1 and 2 to really make an educated decision for you and your baby if you find yourself stuck in the second stage of labor. So that concludes the third part of this 3-part video series. I hope it's helpful. Any questions or comments, leave them below. I'll be happy to get back to you. Until then, thank you. Stay healthy and stay educated. Thank you for watching this episode of Patient Education for the Educated Patient. I hope you found this content both helpful and meaningful, and that you'll be able to use it to live a healthier life. If there's any questions, please leave them in the comments section below. I do welcome feedback, so please also leave me any comments or suggestions in the comments section. Please subscribe and turn on the notifications, and I hope to see you at the next episode. Until then, stay healthy and stay educated.